I've been interested in epilepsy since I left medical school, really. I did like neurology. I was interested in psychiatry, I was interested in the brain as a medical student. But when I got experience on neurology wards, most of the patients were old. Many of them were suffering from degenerative diseases. And when I first became a doctor in the 1990s, epilepsy surgery was a really exciting new development and enabled us to turn people's life experiences around. It's also a treatment that we tended to offer to younger people and that could change their life course. So that really attracted me to the field of epilepsy. The National Health Service in England is a great social model. It enables people to receive treatment at the point of need without the need to pay, and with a minimum of administrative burden. Compared to the situation in Germany, it is much easier to be a patient in England than here. Especially private patients in Germany will have to reclaim their health expenditure, who have complicated arrangements with health insurance. In England, nobody has to think about their health insurance. The cost of the healthcare system is borne by taxes. Having said that, the system has been starved of funds for the last 10 years. And in my career as a consultant neurologist, I experienced a good 10 years of continuous improvement, where waiting times were coming down every year, where treatment options were increasing, where novel treatments were made available. And then 10 years of decline related to insufficient funds and insufficient staffing. And it's been quite painful to go through that experience. Right now we're all hoping that change may come and that we can turn the health service round again. But at the moment there are unfortunate gaps in healthcare provision everywhere. So whilst the NHS provides access to all manner of epilepsy treatment, to the whole panoply of anti-seizure medications, to whole genome sequencing for anyone who would be a candidate for that, to epilepsy surgery, to psychological therapies. Often these treatments are very difficult to access in practice, and there are waiting times along the way. It can be difficult to secure referrals and then to have the various tests that might be necessary for advanced treatments. So whilst in principle it's a great system, in practice it really creaks. Nevertheless, I still get the impression that healthcare provision in England is somewhat more uniform than in Germany, where there are centres of great excellence like this one, but where there are also areas where neurologists will hold on to patients who they don't really know how to treat, but because they get paid for their activity and for the number of patients they treat, they're tempted to practice beyond their capabilities. Whereas in the UK, neurologists get paid a salary and on the whole try to deliver the best service for their population. And there is nothing to be gained by a neurologist holding on to a patient they don't know how to treat. Almost all neurologists work in groups, and within the groups there are likely to be neurologists specializing in all the different subfields of neurology. So I think it is much easier for patients in England to be sure that they receive appropriate advice from the most relevant subspecialty expert, then that would be the case in Germany. So there are many gaps and there are many differences. I think for people who are well orientated, who know how to work the system, possibly Germany is a little easier, but actually those people would also be able to work their way through the English waiting list slightly more quickly by knowing who to ask and how to ask. So I think really there are differences, but in terms of quality and delivery, the outcomes are likely to be similar. Yes, so today I gave a lecture on the relationship between trauma, functional dissociative seizures, and general health. The main point I made is that, or the main points I made were that trauma is an important factor in the etiology of functional seizures, but it is not ubiquitous. So there is a group of patients, maybe 10, maybe 20%, who will deny any relevant traumas, and in whom even psychotherapists who spend considerable time with them may not detect any trauma. So dissociative seizures can occur in the absence of trauma, and probably for different reasons. But the majority of presentations do seem to be related to trauma, and when we talk to our patients, in Sheffield we have a psychotherapy program involving 8 psychotherapists. We tend to hear stories which make it very likely that it's not just a coincidence that patients who then develop dissociative seizures were traumatized, but that there are clear relationships between trauma and dissociation or dissociative seizures. One thing that makes me come to that conclusion is that it's not trauma generically, but that certain traumas are more closely linked. So, for instance, childhood traumas, sexual traumas, traumas involving lack of agency by the traumatized individuals, traumas perpetrated by people who should have provided emotional support to the victim of the trauma. So these are traumas that are particularly likely to be linked with dissociative seizures. There's also a lot of evidence from the field of post-traumatic stress disorder and some evidence from series of patients with functional dissociative seizures that these seizures are linked with bad physical health and related to increased risks of a host of different physical conditions like heart conditions, chest conditions, cancers. So future research will have to explore what the nature of these links between trauma and general health is. There are a number of possible explanations, including increased stress and continuous activation of or persistently high arousal associated with higher blood pressure and poorer cardiac health, but also perhaps the presence of silent inflammation, so chronically raised inflammatory markers, raised pro-inflammatory interleukins, abnormal mitochondrial function, abnormal functioning of the immune system, premature aging of the immune system. So these are all phenomena that have been described in people with post-traumatic stress disorder. And I wonder whether we will also find evidence of this in people with functional disorders, and whether that evidence will help us understand why people with functional dissociative seizures have increased premature mortality rates, which are very similar to the increased premature mortality rates of people with epilepsy.